right, before we leave the topic of acute lymphoblastic leukemia, we do have one FDA-approved drug on the basis of unmet medical need, and that is in second relapsed ALL, the liposomal vincristine product. It's already being studied in frontline older patients with Philadelphia chromosome negative ALL. It's also been used as a bridge to transplant. How do you feel about that as a therapeutic endpoint, especially a regulatory endpoint? Anybody on the panel?
Well, the FDA is very open to surrogate endpoints for accelerated approval. They really have not yet been presented, I think, with the data set that will clearly address this. But the question is, if you can meet a specific surrogate endpoint, such as getting to transplant in a minimal residual disease setting, is that sufficient for accelerated approval of a drug? And it may well be if the data are clean enough. I think definitive approval will then need to show that this translates into prolonged survival. But we had several FDA meetings a year or so ago on this topic in ALL, AML, and CLL, focusing on surrogate markers, and I do think that they are open to this concept, and it's really a matter of designing a trial that will address this in a prospective manner rather than retrospectively trying to use this as an endpoint.
I think particularly for a surrogate endpoint that involves potentially a curative therapy, and if a therapy gets people to transplant and you can show a subset of people are cured, then there's no better reason to provide. There's no better unmet need than being cured versus passing from your malignancy. But it's an endpoint that's really hard to get around because some of these therapies can negatively influence the transplant as well, and you really have to be sufficiently powered to look to be sure that the patients are going to be able to get through the transplant after it.
True, and it seems as single agent the drug can be delivered and deliver a large amount of drug without myelosuppression or significant myelosuppression, and that's one of the abstracts being presented, oddly enough, at this meeting in melanoma, where repeated doses of liposomal vincristine was not associated with much in the way of marrow toxicity, and so it does seem to deliver patients in remission to subsequent transplant definitive therapy.
This group of patients is very difficult to manage as well. The second relapse of acute lymphoblastic leukemia, they've had most active drugs at this point, and so to be able to get them into a fairly minimal disease state and then transplant them, I think is a reasonable surrogate endpoint, as Dr. Bird mentions.
Since this is the only approved drug in ALL, and it's easy to give, all the patients that we studied already had received vincristine in the past, and there's no added toxicity or neurotoxicity, which was the main concern. You said there was no marrow toxicity. This is a drug which is actually suitable as opposed to all the new technologies to physicians in communities, because you don't have to come to the hospital. You just give it once a week, like vincristine, and if it has the single agent activity that is reported, CRs of 20%, overall responses of 35%, you might have more patients getting into transplant because nobody expects this to cure them. It's also a good palliation that, again, can be given at the community without the patient needing to come to an academic center.